very dormant, did not even have a board. But you took the step and you put it in place. That have taken long to sign. We were supposed to sign on 2nd of February, and there was an invite from the Council of Governors. But as we sit here, only 16 counties have actually signed. We don't understand why the others have not signed. And it's something that, Your Excellency, if you can be able to mediate, we can be able to conclude very fast. Thank you, Your Excellency.
Thank you, Peterson. Now, that's quite a handful, of manenos, but I think it's very good feedback. Let's begin, and I agree that machines, computers, medical commodities are all good, but without the personnel, they remain items, and they cannot, they cannot amount to service. For it to amount to service, people must be there. At the heart of health delivery is the health workers. And let me say the following. Peterson has put me squarely on what I said when we had the health summit before the last election. And I'm very happy to see you, Peterson. We have not met since that time. The problem, you forgot to come with the photographs. and I already gave you the leeway. I told you, keep these photographs so that in case I forget, remind me, tell Mr. Boss tulikubaliana hii. Unaona hii picha. But I guess you also agree that 80–90% of the things we agreed at the Catholic University, we have implemented. There are some outstanding issues, among them the issue you have raised, and I'm going to see how we can navigate so that we can take this forward. So human resource is a critical part, possibly the most critical part of the delivery of health as a service. To give it to the counties, and when I said I'm going to be an arbiter, you can confirm. And the chair of the Council of Governors here and the governors can confirm that the relationship between the national government and the county governments is way better than it has ever been. Because I deliberately chose to work with the counties, to engage in dialogue, and I must also say the counties have been very understanding. Whether it is the payment of CHPs, we've done it together. Whether it is the passing of the laws, they were always in the committees. Whether it is the equipment, the National Equipment Service, we have an intergovernmental partnership agreement. And everything else, we have worked together. Now, up to that point, we are good. You have raised, Dennis and my good friend Seth there have raised issues that I'm sure the council will want to respond, because this is not a place for judgment. This is a place for feedback, so that we're encouraged for the things we are doing right, and we are pointed out the things that are not going on in the right direction so that we can improve. It is true what I said yesterday, and the chair of the council can confirm that we have transferred all the resources for last year. We never crossed with any shilling belonging to counties. And the money for July was already paid. The chair explained yesterday the reasons why some counties have not paid the July salaries. But what these good people, representative of health workers, Dennis and Seth, are saying is also correct. You know, if today is the 19th, right? 19th of August, and salaries of July have not been paid, there is a problem, you know. So we need to tidy up that, because otherwise we demotivate the most critical aspect of our health delivery. I agree with you, and if there is anything that the national government can do to support the counties on that matter, we are willing to go out of our way to support the counties so that that matter can be sorted out. The next issue is the issue you have raised on deductions, and that by the 9th, when SHA says that you haven't paid and therefore you cannot get service, I thought we created a bridge. I thought mercy, you know, because it is not right that we don't provide service because an employer has not remitted the money, which they are going to remit anyway, you know. So I think that we had that conversation. I don't know whether Mwai or somebody or yes.
I'm being told to do it, Your Excellency, so because it's hot. Your Excellency, yes, we did have that conversation, and we agreed to move from the 9th to the 25th. We just need to tie up an agreement with Treasury and then be able to work that round. So we haven't implemented it yet, but you did initiate those discussions and give us the instructions that we sit with Treasury and move from the 9th to the 25th, at which date Treasury had committed that all monies would be with the counties and we wouldn't run into this problem. So it is on us, Your Excellency, we will need to implement that.
Yes, Aden.
Your Excellency, this is a matter that we have discussed a number of times. That healthcare workers who are treating Kenyans on the 9th themselves are locked out. And when we were at the summit, I think why we kept is that, and the chairman was there at the summit in December, we found out that the majority of the counties were committed to paying before the 9th. Wajir is one of them that has been paying before the 9th. I think what we are not discussing here is the flow during the transition of the two financial years. But Treasury have been dodgy. We just need to do an MOU with the National Treasury. We are the ones who pay both the national government and they pay the county governments. At times even we have a problem with our own civil servants, the chief contribution. So I think this is a matter that ourselves and the chair can now get just a final MOU commitment with the National Treasury, and we should not discuss it anymore. I think the healthcare workers, you can assure them of that commitment in the next 2 weeks.
All right. So let me tell the representatives of our healthcare workforce that this is feedback that had come to me, and I had already given direction on what we should do, because it is not correct that a healthcare worker is providing a service to others which they themselves cannot benefit from. It's a contradiction. And secondly, this is a healthcare worker who has a contract. They are not about to run away in between the month. So whether it is the 9th or the 20th or whatever, they will pay finally. So to the good people, Dennis and Seth and Peterson, that is good feedback. I will deal with it. And we will make sure that no health worker is locked out on account of the county having not remitted their deductions, and then we will see how to work this out with the counties, right? Dennis, this is not a demonstration. Then the third issue which has been raised, and I will give you, Chair, I will give you time to respond, and also Abdul Samad. The third issue, by way of feedback that has come to us, is the outstanding CBA agreements with nurses and with the other health care workers, and the need for us to bring on board the Salaries and Remuneration Commission. The Salaries and Remuneration Commission, as we all know, is an independent institution, but we will socialize them to the need for us to have an agreement with the Council of Governors and with the health workers. So again, that is some homework for me. I will make sure that the SRC comes on board. I'm sure the Council of Governors will also do their bit, and they are here, they will speak for themselves. Finally, is on the issue of the staff, former staff of UHC. We did make available resources to transition these good people to permanent and pensionable. We made the resources available. We just have a minor issue between us and the counties, which we should be able, I think, Chair, ladies and gentlemen, let us sort this out. And let's give ourselves a maximum of a week and sort this out. I have given options. I have said, if the counties have a problem absorbing these workers, the national government will absorb them. So it is up to us to, but I would really, because I know the risk of us absorbing them as a national government, because it will undermine service at the counties, because we will basically be transferring staff from our county facilities to national government facilities, and yet at the county facilities they are providing service to Kenyans. In any case, we don't have national government Kenyans and county government Kenyans. We only have Kenyans. Yeah? So I think this is something that between me, I undertake that between me and the my good brothers and sisters at the county, we'll look at it. Chair, and then Abdul Samad.
Your Excellency, let me have a first go at it, and then my colleagues will back me up. Your Excellency, we are good friends with these union people because we spend a lot of time with them as governors navigating these matters. But the things said here should not take away from what counties have been able to achieve in this sector. This morning when we were in the other hall there, we took cognizance of the fact that in 2013, in the run-up to the first elections under the devolved system of government, we had about 900 doctors in district hospitals. Today we're talking of close to 5,000 doctors in county hospitals. Your Excellency. Your Excellency, you very well know that I'm a returning governor. I served in the first term. I was out for 5 years and I'm now here. I inherited Wajir with one doctor. I think that one doctor is here. Dr. Somo, I don't know whether he's here. He was in the hall today. Today, we have over 70 doctors, of which over 20 are specialists. I remember advertising for a consultant 3 times, and no Kenyan was interested to come and work in Wajir. And I went and sat in the office of General Kaiseri, and I said, you need to give this Ethiopian doctor a work permit because he's a consultant. I can't find a Kenyan consultant. And that Ethiopian doctor was the only consultant in my county for years until we sent our own doctors to go and specialize and become consultants. He died in a road accident. He's called Dr. Janai. People know him in the medical profession. So the things people say here about counties and devolution are not, it's not what it is, Your Excellency. Your Excellency, there are things, I think this reaction, first of all, emanated from what Governor Sakaja said about people being sent to private facilities, and I'll respond to that last. It is true, Your Excellency, and I said it here last night. Since you came into office, we have not had instances of crossing over and merging finances of one fiscal to the other. It was very ordinary in the past for June allocation to be paid in July or in August. We have our June money. We have our July disbursement. But there is another matter, Your Excellency, of the treatment by independent officers and commissions, and especially the matter of COB with respect to county governments. We have asked for an IBEC, which His Excellency the Deputy President chairs, and IBEC will happen on Monday. This will be one of the issues that will be discussed. As for those counties that are yet to submit a budget, Your Excellency, those are the vagaries of democracy. Budgets are drawn by the executive, but they're approved by the county assemblies. And sometimes they take their time. And they sometimes, you know, and we don't meet certain deadlines. But the financial architecture has taken care of that. Even when a county has not passed a budget, the law, PFM Act, allows that county to access 50% of the last year's budget within the first 6 months. So those are things that we will navigate. This particular incident here of 33 counties not being able to pay salaries, as I said last night, is just as a result of the fiscal year transition from one to the other. Once all these budgets are approved and uploaded into IFMIS, it happens once a year, so it will not be an issue. Most of the time in the past, it has been an issue of disbursement and releases of money. In this particular case, Treasury has disbursed. We are having crossover issues, which we will deal with on Monday with COB and at IBEC. Your Excellency, on the issue of CBS, as far as I'm concerned, Your Excellency, the only active issue, strike, which is not in all the counties. Nurses are not striking in my county, for instance. We have talked to them, and we are doing their promotions. We have promoted most of them. They have no issue, they are at work. But in some of the counties, I know, nurses are striking. The CBA that they're asking us to enforce today, Your Excellency, and I can easily provide a copy to you, was signed in 2017. 2017. And when they came to see me, I also blamed their leadership. I said the clinicians came and formed a union after this CBA, and they still had their matters largely sorted out. If there are counties that have not signed, because we have already made that commitment at COG level, that's an issue you don't have to call a strike for. You just need to speak to me and tell me which counties. But, Your Excellency, this CBA of 2017, I asked the union leaders, how many chairs of council have been here? President Ruto was not even the president then. How many ministers of health have been here? You are raising it now. But the amount we're asking for is what was to have increased from 2017 to date, when a shilling has not increased. So we met as a leadership and we made a very good offer. And we also told them how we will move to where we ought to be. Given that nothing has moved, not a dime, from 2017 to date, and they are to come back to us on the offer that we made to them. As chair of council, I am determined to ensure that we have an understanding with the nurses. But I want to say here now that the CBA, which they are asking me to effect, was signed in 2017, and nothing had moved on it. Your Excellency, the question of whether health should be managed at national and county level is a constitutional matter. But I just want to give you an analogy, Your Excellency, because there's another elephant in the room, and that's the one of supervision. And Masakela is my good friend. Your Excellency, every time, because no sitting president of this country understands Kenya more than you do, because no one visits the periphery and every county more than you do. Whenever there is an attack of some sort, a bandit attack, an opportunistic attack by Al-Shabaab, in a place like Mandera, Wajir, by virtue of proximity to the boundary, teachers, some of whom are 300 kilometers from where the incident happened, come and demonstrate in front of TSC to be demanding to be taken out of the region. Yet the incident happened where? 300 kilometers. 300 kilometers between here and Busia. So it's something happening here, and somebody in Busia asking to be transferred out of Busia because of insecurity. Those are the shenanigans we will be dealing with if we go the way Masakela wants us to go. Counties have no problem managing healthcare. 5 or 6 of His Excellency's cabinet secretaries were governors managing counties. There is not a single governor today who cannot manage a docket at national level if he gets the opportunity from His Excellency the President. That is not the problem. The problem is systemic issues that we have to deal with. The approval of funding by COB and the like. Your Excellency, coming to the last matter, which is the matter of conflict of interest. Conflict of interest. And I know this is a very, very, and should I say, sensitive matter. Your Excellency, the problem you have in this country, which is a good problem, is that you are running a very democratic country. And democracy limits your hands in dealing with certain things, just the way it also limits my hands as a governor. We have a situation in our counties where doctors who have been trained with government money, some of whom are consultants that counties have been paying their salaries, and sometimes they're away for as many as 5 years. I have one who was away for 9 years. He's specialized and specialized father. And then COVID happened, he stayed longer. When they come, what do? They set up specialist clinics next to our hospitals. And they want to use the government salary as a retainer, as a safety net, but earn more money running their private practice. And these are the issues that we're having with our doctors. And I don't want to raise it here, but we're having a frank conversation. Those are the issues that we need to deal with. If you are in public service, there's a clip that's going around the last 2 days. I don't know whether whether you have seen. The pediatrician in Turkana. A Kenyan, I don't know whether that was on national TV, saying he met this pediatrician in Turkana who does 4 days a month in Turkana. He does 4 days a month. Your Excellency, is it fair for the Kenyan taxpayer to pay a consultant 400,000, 500,000, and there are consultants who earn 700,000? I know consultants who earn more than deputy governors, Your Excellency, and I can provide you with this data. To work for 4 days a month? I think those are the things we need to discuss with. Having said that, Your Excellency, I will make an effort as chair of council to even get into an arrangement for the purpose of salaries so that we allow counties that are having challenges paying salaries to also have a soft arrangement like some of us do with Kenya Commercial Bank so that they pay salaries on time. I can face Panyako because I have paid my salary, I have paid my chief, I never delay in doing it, but you cannot come and generalize things here. I thank you, Your Excellency.
Thank you very much, Governor. Do you wish to say
Abdul
something?
Samad, please help me.
The chair of Committee of Council of Governors, briefly.
I think we know each other with the union leaders on first-name basis. And I think the number of calls that I get from them in communication is probably more than what I discuss with you. I want to start, an example is Peterson, Kenya Union of Clinical Officers. The last conversation I had with Peterson was actually just yesterday, Your Excellency. And it was myself, together with Governor Sang, that actually negotiated the return to work formula. There's some things, Your Excellency, that are beyond us. SRC is a constitutional body. I have to go out of my way, and the Secretariat, the able Secretariat of the Council of Governors have to go out of their way because we need a no objection from SRC. I signed, other counties have been able to sign, others are in the process of being able to sign. But even after that goodwill, you're still being told that, and I actually had to call him and tell him there's a level of goodness that we can also be able to do, because if we have signed and have done our part, there's really so much that we can be able to do. The doctors, in fact, I know that I'm meeting them on Thursday, actually, Your Excellency, which is tomorrow. Is it tomorrow? Yeah, on Thursday, I'll be meeting the doctors. Some of the issues that we've been able to do and work on. Today, we're implementing a CBA, including paying salary arrears, including, we actually had to personally call the head of the Ministry of Public Service for purpose of getting a special code for ensuring that we pay the salary adjustments and so forth. The issue of nurses, Your Excellency. Prior to the strike being in place, the Council of Governors had already put a team and they were already negotiating. Negotiations had already started. And even without anything else, the nurses opted that, yes, they want to go on strike. I've heard the issues that have, you know, and it is okay. It is okay because of positions that we hold sometimes, it is important for unions to be more tough on counties like ours. Because of the fact that maybe we speak on behalf of the other governors. But I, like the governor of Wajir, I think probably because of this transition, for the first time, I delayed salaries by 2 days or 3 days. I have no debt with any single employee in the county government, including statutory deductions and everything else. The issue that we're trying to make sure that it does not happen, you need to ask yourself, Your Excellency, what were the conditions that made a CBA to be signed in 2017 that every government that has been able to come through has not been able to do a CBA like that? When you sign a CBA, when you're in a position that you're under duress, because that CBA was signed on an election year. That CBA held people at ransom. Allow me, you know, and it is the reason why, Your Excellency, I sat down with the two gentlemen at the council offices, and we gave them an offer. And we said, this is our offer. The least that would have happened is we're coming back now, even as we speak right now. There are so many who have gone and broken court orders because of the fact that there's actually a court case that they're actually meant to return. Because when you speak to someone and you're holding a gun on their head, you're dictating, you're not speaking. You speak under equal terms, and if we've shown that level that we want to be able to speak, the same way I've been able to speak to the Kenya Union of Clinical Officers, the same way I've been able to speak to the doctors, we were able to sort out strikes, and we were able to amicably solve issues to do with many other cadres that are out there. And I think, Your Excellency, amongst the things that are being discussed at IBEC on Monday, one of them is the issue you were talking about on SHA, that if a county has not been able to pay, what happens in a scenario like that. It is something that is being resolved on Monday as we speak in IBEC. The other issue that is also being talked about, I know Mombasa is not one of them, but it is only fair that I speak on behalf of the other governors, Your Excellency. The issue that is being discussed on Monday is also issues to do with COB. When a county like Nairobi and many other counties have not had their budgets approved, and COB opts and decide that, it is just a uploading or something. But anyway, COB has decided not to do some of these other things in time. And Your Excellency, there's actually a notice that COB themselves have actually put out, that there would be a crisis on salaries. And it's not salaries just for nurses or doctors or clinical officers alone. It is nurses, including the governors and the deputy governors and the CECs and chief officers and everyone else. So, for those governors, the same way we have doctors out there who decide not to go to work, which is a fact. They decide not to go to work despite the fact that they're being paid salaries. One of the reasons why you hear that SHA is not working, Your Excellency, and this is a true story on my part. I went to a hospital and someone could not be discharged because the way SHA works is, and it has been beautifully designed so that there's no fraud. The person, the clinical officer or the doctor has to be able to sign them, and it is because it's geo-fenced. When that person is not there, then you're told that SHA is actually not working. But as a matter of fact, there's a person who was meant to do what they need to do when they were not there. Now, as much as there are doctors who spoil the image, if there's one or two who have decided that, they're not paying statutory deductions, as my chair has said, that is the price of democracy because someone voted for them. It does not mean that the system is wrong. it means that there's someone who did wrong. We do not know the kind of president we'll have after 2032, Your Excellency. We pray for your long life up to 2032 that we take. But what happens when we get someone else who's going to be rogue? Does it mean that the system will have to be now reversed, that things have to go back again to counties? Have we not had situations where this country has had teachers' strikes and teachers' national government? So, Your Excellency, this is a conversation, and I think the issue of human resource is something we need to sit down, and I'm glad you've actually given us a deadline and a timeline. There's a discussion we're having with CS Duale on the issue of UHC. There's no one who does not want. It is only that we do not want a situation where we can have a problem of continuity. That is all that we're saying. But we value every single healthcare worker, we value every sweeper, we value every fireman, we value every single employee who works for our county governments. And please, let's reciprocate on the same. Thank you very much, Your Excellency.
Thank you, Chair. I think that is a fairly balanced conversation from where I sit. Very balanced. I think everybody has said their piece, and very respectfully, but also very authoritatively. And I think we have agreed on a way forward on the CBS that are outstanding. What I must say is, even as we agree here, I am a very big supporter of the Salaries and Remuneration Commission. We must respect their mandate because they help us to balance between recurrent expenditure and all the other expenditures. So even as we negotiate, let us take their view into account so that we balance things out. I agree with the Council of Governors that sometimes we have challenges with the approvals from the Comptroller of Budget, and I'm happy that you have set up a meeting for Monday so that that can be ironed out and we can have the counties to discharge their responsibility as is expected of them. Let me say two final things on this matter. There is somebody who said that there is an issue about how much, I think it was Panyako who said, some people, when they go and they are being means tested, sometimes they do not get the right, testing, because maybe they said they have this, maybe the assessment was not accurate and that kind of thing. I think that's homework for us. We need to continuously sharpen the means testing instrument. That is homework for at least my office, especially Mwai and the professionals who work with me, so that we can assist the ministry to sharpen the means testing instrument. Is that correct, Mwai? Yes. I want to just promise you that we're still collecting data on making sure that when we do an assessment of a citizen on how much they pay, we must be as near accurate as possible so that we do not burden a citizen who has a certain ability and we misjudge them to have a different ability. So that is a good feedback, but already it is in our radar that we have a means testing instrument. We are still gathering data, and we are we're trying to access data from different sources so that we can have a much more accurate means testing instrument. Let me, however, say that there are people who have means, and this is Kenya, There are people who earn more salary, they have better businesses, but you will find them complaining that they want to pay the least. When in actual fact, they should be able to pay more because the assessment that they go through says a different thing. So we must continuously not burden, and I must say this, the people who earn salary, everybody knows their salary. But there are people who make as much money doing business, but they don't want to pay as much as those who have a salary pay. They want to pay less. That is unfair. In fact, the court instructed us that we must be fair. You know, those who have a salary must pay. Those who don't have a salary must also pay, and they must be assessed correctly. So I think that is an area that we will keep improving as we go into the future. One final thing that was said is on the matter that Peterson raised. I think when we were in that summit, when I made commitments, I said we will find a mechanism which will bring the county governments and the national government into a place where we can discuss health, human resource issues. You remember Peterson? And that is the reason why we set up the KHRAC, right? The Advisory Council. Maybe it is not doing exactly what, maybe it's not very effective. I think we should find a way of making that body much more robust and active before we can explore the opportunity you have said that maybe under Article 189, I don't know whether that is possible, for us to set up an something to deal with human resource. But I think the best place to start is the advisory council that we have. Let's see whether we can put some energy into that organization and see whether we can manage the human resource issues collectively as the national government and as the county governments. And I think we have agreed on the UHC staff. Within a week, myself and these good friends of mine, governors, we will agree on how these workers are going to work and move forward. We have also agreed on statutory deductions. That is my homework. That I will sort it out. We have to, because it's not right for us to deny citizens who are working access to health on account that their deductions have not been received by us, yet they have already been deducted, and they will be paid anyway. We must find a solution. With the Treasury, without Treasury, Aden Duale, please sort that out. If you need some ideas on how, look for me. I will give you some ideas. I think those are the issues. I don't know whether they are Mercy.
Thank you, Mr. President. I think we have discussed the healthcare workers quite comprehensively. Next, I'd like us to have a conversation on renal care. It's an important conversation because in there are issues of non-communicable diseases such as diabetes and hypertension that can cause, complications on renal care, the issues of dialysis, the issues of transplant, and also the immunosuppressive medications that transplant patients sometimes require. So I think we can unpack all of that and have a conversation around it. So we can start by somebody with a lived experiences on renal care. All right, you're already up. Please, the floor is yours.
Thank you, Mercy. Your Excellency, distinguished ladies and gentlemen, my name is John Gikonyo. I am the president of the Renal Patient Society of Kenya. I'm also the vice chair of the Non-Communicable Diseases Alliance of Kenya. I am a kidney patient myself, living with a kidney transplant. I got my kidney transplant in 2015 at the Kenyatta National Hospital. And I'm proud to say that between then and now, the good people at Kenyatta National Hospital have taken good care of me and other renal patients. And that's why I have known nothing but good health in those 11 years. Your Excellency, I represent a group of people who are considered to be the greatest beneficiaries of the Social Health Authority. And I say this because the cover we have for both dialysis and transplant is, honestly speaking, quite generous. A patient on dialysis in Kenya is covered for 2 sessions every week, each session at 10,650. If you total that for 1 year, it's 1.1 million shillings per year. Now, a lot of people would not be able to pay 1.1 million shillings to pay for 2 sessions per year. And therefore, the 7 or 10,000 people currently living on dialysis literally owe their lives to the Social Health Authority, and we don't take that for granted. The patients who are lucky and able to get a transplant like myself, we have a share package which covers, again, 1.1 million. That is for pre-transplant evaluation. Then there is the transplant surgery itself. There is the donor nephrectomy, that's removing the organ from the donor. And then there is the post-transplant management. If you total up all those figures, they come to about 1.1 million shillings. And therefore, we are very grateful to the government and to SHA for this package. And we would like to encourage SHA to continue supporting us. We would like to encourage SHA to speak to us regularly, because sometimes there are challenges, particularly access challenges, that need to be ironed out so that whatever is not going on well can be sorted out. And I would like to pick a few issues. The dialysis package, like I've said, is 2 sessions. But if a patient gets admitted, if a dialysis patient gets admitted to hospital, they are only covered for 1 session. And this is a bit strange, because if you are on dialysis, you are already a patient who is unwell, but if you now need to be admitted, it means your health has deteriorated, which could probably mean you need more dialysis than the 2. Remember, international best practice recommends 3 dialysis sessions. But we only give 2 because that is what we can afford for now, and we understand that very well as patients. But we only get 2, despite recommendation of 3 dialysis sessions, we get 2 because that is what we can get for now. And I'm talking about now a patient who is getting 1 session because they have been admitted. So they will even get more sick, because if they are not able to pay for the extra one while they are in hospital, then they will not get well very soon. But what is even worse, Your Excellency, there is a condition called acute kidney injury. And this is a sudden onset of kidney failure, either from an infection, an injury, an accident, or something like that. If acute kidney injury is tackled quickly and intensive care given, which would involve, for example, 5 full days of dialysis, there is an 80% chance that the condition can be reversed, kidney function will be regained, and the patient can go home well. But now when we only allow 1 dialysis session for this patient, because they are any patient, what we are doing, I'm imagining the reason we are doing this is so that we save some money. But what we end up doing, and this is very sad, is that we are saving 50 or 60,000 at the risk now of sending this patient to full-time dialysis, for which we will need 1.1 million per year, and they will have a very bad outcome and a reduced quality of life. So these are some of the things we would like that SHA to reconsider, so that people get the care that they need at the time that they need it, because some of the access rules, unfortunately, are not fair to the patients. We have, like I've said, a post-transplant package. This is a package which supports now the medication and the clinics that we need after transplant. I would like to thank your government and SHA because this is new. This came with SHA. We had a dialysis package and a transplant package before with NHIF, but when SHA came in, we made a plea and it was accepted. We now have pre-transplant evaluation and post-transplant care. That we attribute to your government and Social Health Authority. Again, we have some challenges with access. Some of them are from the system, particularly the DHA system. We have a very, very cumbersome system where we have to give a lot of paperwork. KNH has now gone paperless. Hata ukilipa pesa upate risiti siku hizi. Hakuna karatasi KNH. And we are happy because things have improved, things move quick. But when it comes to SHA, I have to go with 6 documents, which I have to submit, and they have to be scanned. And even the physical part of doing that and taking them through all this takes a lot of time. Sometimes the system hangs. We would like the SHA system and the DHA system to be streamlined so that we can also go as smoothly as the rest of the things. And sometimes we are forced to go home without drugs because the system hanged. And to respond to CS Duale, who mentioned about, sometimes people switching off the system so that we can pay cash. A lot of time when the system goes down, you can't even pay cash. It goes down, nothing can happen. It's a very difficult and sad situation. And people at KNH, for example, wouldn't do that. And like I have said, I've been with them for over 10 years, so I know them. They cannot switch off a system to make you pay. So whenever it happens, it's a genuine problem.
Okay, thank you, Gikonyo.
Yeah, let me just finish because the President gave us a challenge to talk about beyond 2030. And I have not heard anyone talk about it, so I would like to make some asks on that. And what I would like to ask Your Excellency, and some of these things I would need to seek your personal intervention, is that we need a renal registry. We need that because we would like to make data-driven decisions around kidney disease. We do not have a registry as yet, so a lot of figures we throw around are imaginary. But before we get there, I would like to make a plea to Dr. Mercy Mwangangi and the gentleman from the DHA. I know if you go into your system, you can be able to tell us, for example, how many people accessed post-transplant medication in one period, how many people accessed dialysis. And if you can share that information with us, including with Dr. Lesiampe and her team, and his team, they would be able to make better plans. And I'll tell you why. Currently, that post-transplant package is only available at KNH and MTRH. But they cater, KNH can tell you how many people they have transplanted since they started. But they cater for people who are transplanted in other hospitals, including outside the country. So they cannot be able to predict properly today how many people will come for clinic next Tuesday if they do not have this data. And so they find themselves in problems which they are not able to solve because there is some darkness around how many patients need this service and how do we prepare for them. So we would like Your Excellency for that. We propose that this registry is domiciled at the Center for Excellence for Urology and Renal Disease Services, which we have been promised will be commissioned very soon. And I saw CS Duale inspecting that compound recently, so I know there is something in the works. And if this can be domiciled there, then we can be able to interact with that. And we will have to have, like I said, data-driven interventions and preparation. Now, I would like to bring to your attention, Your Excellency, that the Kenya Blood Tissue and Transplant Service has, for very many years, been trying to come up with a deceased organ donation program. And the reason we are doing this is because currently, if someone needs a kidney transplant, they can only get a donor from within the family. So previously, before the post-transplant cover that I've said came with SHA, a lot of people are preferring to stay on dialysis because when they're on dialysis, they don't pay anything other than the subscription. But if they do a transplant, they need to buy medication, and they feel they cannot be able to do that. Now we have some money coming our way. And the question is, why haven't we seen an uptick in people seeking transplant services? The reason is kidney disease is a family disease. So if I am still being requested to go back to my family to look for a donor, there's a high likelihood that most of them will not qualify because if it's a genetic disorder, then they are all affected. And that now keeps people on dialysis because the only exit from dialysis is transplant. So if you cannot get it, you're stuck in dialysis. We think that your quality of life will deteriorate if you are on dialysis for more than 5 years. So the cure for that then is a deceased organ program where we can be able to take organs from our dearly departed and then we can use this for transplant. We can also relax the rule that requires me to go to the family so that now my friend or my neighbor can donate to me. The Kenya Blood Tissue Transplant Services has been working on a framework to operationalize the law that is in the 2017 Health Act. And this process has been stuck since 2023 because of lack of funds. I would like to make a special appeal to Your Excellency and the Honorable CS for Health. Please make sure that this effort is funded so that we can be able to finish the technical co-working group that was working on this is able to finish his work so that we can expand the donor pool in the country and more people will be able to exit dialysis and go for transplant.
Thank you.
Just two more.
Thank
Okay.
you. Let's allow others
let me talk
feedback.
about an NCD. I would like to request that I know we're having a census in 2015. Again, looking for data. We don't know how many people are living with NCDs in the country today. I would like to make a request that during the census, the next coming census, that we put a question on NCDs so we can have some semblance of data of the people living with NCDs in the country. And finally, I would like to make a plea for meaningful involvement of people living with NCDs at the decision-making level so that we can contribute towards some of these decisions using our lived experiences, and that is the end for me. Thank you very much.
Thank you very much, Gikonyo. You have packed quite a lot of things, and I could see the President taking notes. We will address that later. Allow me to also just pick 2 or 3 more lived experiences. There was a couple, and yesterday we had a conversation on seeking care in public hospital and those who go to private hospital. So there's a couple who had an accident, Mr. President, and had both experiences in a private or public hospitals that wanted to share that story. Oh, he's here. You can just
Thank you, Dr. Massa.
You can just...
It's okay.
Thank you, Your Excellency. My name is Joseph Mutinda Kimatu. With me, I have my wife.
I'm Frida Mutindi.
Yes, we got involved in a road accident on 1st of March this year. On our way back to school, we are teachers in profession at TSC, and we were admitted in Machakos level 5, but because of logistics of surgery, I was the one who was left at Machakos level 5, and then my wife was referred to German Medical Center in Machakos. So we went through surgeries because I had a acetabular fracture at my right leg, And then my wife had a femur fracture on her right leg also. And throughout the process of treatment, I took around 3 weeks to have everything taken care of because of mid injury and also some scars you can see in my head. And, she took 1 week in German Medical Center. The bill that was there in Machakos for me, it was 224,000 and ours was 145,000. And comprehensive cover, which is also included in SHA, everything was catered by SHA, around 369, almost 370,000, and no single cent we paid for that service. We have also been going for the clinics and also for the checkups on MRI, CT scans, X-rays in imaging center at Machakos, and everything has been taken care of by SHA. So we are here to witness and confirm that through that deduction, Mr. President, you said yesterday that cuts across all the civil servants, we benefited fully without paying any single servant, and I'm sure every civil servant here can also confirm the same. And I have to congratulate you also, Mr. President, for being in the forefront to launch that program for emergency services. Because, for example, in our case where we got the accident, it was somewhere in the bush area, somewhere where we were going in work, and it was out of the Good Samaritan we survived in that accident. So thank you so much, Mr. President, for being the forefront to ensure that the health care in this country is working well, and we truly say we appreciate for that service. Thank you.
Thank you. Thank you very much. Mr. President, yesterday you spoke about Linda Mama, Linda Jamii, and on my corner here I can see a few moms and their babies. If there's any who would want to give the experience, kama kuna mama yeyote ambaye angependa kuzungumza, hata kama si hawa pale, kama kuna kina mama yeyote, naona kuna mmoja pale.
Okay, for me, I would like to talk on behalf of mothers with children with disability. Personally, I'm a beneficiary for Tenweg and Bethany Kids Kijabe. Those two hospitals, my son have benefited his spina bifida. He has benefited on the surgeries. The 3 surgeries that were done for him, it was around 300,000, and all of them were sorted out, both in Tenweg and both in Bethany Kids. So personally, Mr. President, I'm so concerned when it comes to early interventions for children with disability, especially when it comes to therapies. I would really ask if SHA can help us in accommodating our kids on therapies, because there is where we have a lot of challenges, Mr. President. Again, we have issues with diapers. Yes, yesterday you guys talked about diapers. Our children also need diapers, because that is where we have so many challenges. We have mothers who are still wrapping their big children with cloths because they lack diapers, and that one is like lacking hygiene when it comes to that. And again, we really like, as caregivers for children with disability, we really like if we can have a mental health rehabilitation, because we have a lot of challenges when it comes to raising children with disability. And also, I would really like to urge SHA if they can help us in assistive devices, if assistive devices can be placed at SHA also, so that most of our parents can see on a better option when it comes to orthopedic area. And lastly, I would really like you, Mr. President, to consider our national days when we celebrate disabilities days. Like September, we'll be celebrating World Hydrocephalus Month. So if you can celebrate with us, we'd really appreciate that. Thank you.
Thank you. Thank you very much. We have a team from Moyale, and I know sometimes people who, or Kenyans who live at the periphery, have access. Okay. Aya, simama basi zungumzi kabla tuende Moyale. Ongea tu, ongea. please, weka microphone. Karibu, karibu.
SHA ilinisimamia kila kitu, and my SHA was temporary SHA, and it has already expired. So pia nilikuwa nauliza if I can renew it, because I'm underage.
Just hold on, eh? Can you begin? I didn't get your first part of your conversation, please.
Okay. I'm Stephanie Muya. I'm 18, and I gave birth at Pumwani, January date 2, and I used temporary SHA, and it has already expired. So nilikuwa nauliza kama I can renew it, the temporary SHA, and then bado sijapata ID. Na hiyo temporary SHA bado itasimamia mtoto wangu. Ndio nilikuwa nauliza. Then, apart from SHA, I'm a dropout, and I'm a young mother. Pia ningependa unisaidie. I want to go back to school. That's all.
So, we can go?
Yes.
Okay. I thought first, okay, let's begin. Maybe we can begin with Stephanie. Yeah, Stephanie, by the way, I have a daughter called Stephanie. So, Stephanie, back to school, you will go. Yes. I want somebody to answer Stephanie about her temporary cover. You remember yesterday I said the government of Kenya is going to pay for our teen mothers. Mothers who do not have an ID, they cannot pay for themselves, and so the government of Kenya is going to pay. Mercy?
Yes, Your Excellency, you made true to your commitment. SHA does have 1 billion Kenya shillings that you've availed to be able to ensure we cover teenage mothers. And to date, we've covered about 100,000 of them through that program. And that is what Stephanie is talking about, the temporary SHA program. This program runs until the teenage mother is 18. And so it serves for any teenage mother from the age of from 13 all the way to 18. Once the mother turns 18, we expect her to get an ID and then to be able to pay into SHA. So in Stephanie's case, she's told us she's already 18 right now. She's already 18, so we need to help her to get her ID, and then now we need to find a mechanism of supporting her. But the program that we currently have, Your Excellency, has served 100,000 teenage moms in the country. Fully paid up premium for them and for their family up until they turn 18. So if a mother is 14, she gets cover until the time she turns 18, together with her family.
So what do we tell Stephanie? Stephanie is now worried about herself and her child. And
yes,
I think we'll take care of her going to school.
Yes.
That becomes the Ministry of Education's assignment. We will make sure that we find a school for you and pay for your school fees. But then, what happens to Stephanie and the child?
So, Your Excellency, because Stephanie is yet to go to school, it means she doesn't have an income, so we can enroll her in the SHA sponsorship program that you've also availed resources for.
So, does she qualify under the program we have for indigents?
Yes, she does. She does qualify for the indigent sponsorship program.
Okay, so Stephanie, you remember yesterday I said we have 560,000 Kenyans who we pay for. So we will make it 560,001. And Stephanie. So please include her in that program.
We shall do so, Your Excellency.
Now, I think one gentleman has been, first let me thank Mr. and Mrs.
Mutinda.
Mutinda. Thank you very much, Mr. and Mrs. Mutinda, for saying two things. That you've actually proven to us that whether it's a private hospital or a public hospital, I've kept on telling the people of Kenya this, that once you are registered in SHA, you can go to any facility, and as long as the facility is registered with SHA, then we should be able to cover your bills. And for you and your wife, you have also given me one more confirmation. I had a very candid conversation with the Teacher Service Commission and the teachers' unions, both KUPPET and NAT, and I persuaded them that they were better off in SHA than in private insurance. I think what Mr. and Mrs. Mutinda have shown is that that is actually correct. Because today, teachers who had access to one level 5, level 6 hospital, today they have access to all the hospitals. We've expanded cover. Teachers can go to as many facilities as are available in their locality, and we've made the cover much, much better. And congratulations, Mwalimu, and Pole for the accident. Now, we have one wonderful gentleman, Mr. Gikonyo, there. Thank you very much, Mr. Gikonyo. You are a wonderful Kenyan. You have given us so much feedback. I have written my page, and I've turned over the page to write some more on some of the feedback that you have given us. I like the fact that you agree that we have improved on the cover from what was 400,000 for transplant. It's now 1.1 million. That's correct, Mr. Gikonyo? And from what was covered in dialysis, we have enhanced the amount so you can access more facilities. And we have done many other things to make the life of people like yourself and others who are living with non-communicable diseases, their life bearable and better. You have, however, raised a couple of issues which I want us to address by way of feedback. You have raised the issue of acute situations that if we handled them differently, maybe we would have a better outcome. I don't know whether my team has any views. You know, is it something we can carry as feedback and homework for us to go and think about by way of improving the cover? Because I think the suggestion he's making is, yes, we may be making a little saving by limiting the number of dialysis. But if we dealt with it early, maybe we'll have a bit more sessions, we could actually save the kidney. Is it something that doctors can verify that that is the case? And if it is it something that we can onboard as a different approach to this, as Mr. Gikonyo said?
Thank you, Your Excellency. Yes, we actually have the head of all the kidney doctors in the room. If Dr. Wala is in the room, oh, good. Dr. Wala can confirm that acute kidney injury. He's a specialist. Please talk about it before.
Thank you very much. Thank you, Your Excellency, and thank you for this invitation. Dr. Jonathan Wala, the chair of the Kenya Renal Association. My colleagues call me president, but now I'm in front of you. I cannot say this as well. John Gikonyo is a good friend of ours, and we have worked a lot in the renal space. Acute kidney injury is an acute situation that can affect anybody, especially can affect children with severe diarrhea, can affect mothers during their pregnancy, or anybody who becomes sick. During that period of time, unfortunately, we don't have several things about the cover. The first one is about the way to do dialysis. That means there's no cover for the insertion of the catheter itself. And that's a major hindrance into entering into dialysis. The second one now is what Konya pointed out about the once-a-week cover. And that's what we want to try and see whether SHA can address that to improve the outcomes of kidney failure patients. Beyond that, there's care for that kidney patient so that we don't have anybody else coming back for chronic kidney disease and therefore a maintenance dialysis that costs a lot of money. And that's what we are looking forward to SHA addressing. Thank you.
Thank you very much.
Your Excellency, I wanted him to come in just so that as you give us that homework, we're able to be aware that these would be many, many cases, meaning they would have, and he's right, they would have a cost implication. So all the mothers, should they lose blood while pregnant, delivery, they become potential candidates of AKI. And so it's many Kenyans as opposed to the 25,000 who we currently have on continuous chronic dialysis. But we will do the homework and do the numbers with Prof. Jauko and determine what the impact would be, budget impact would be.
Thank you very much. Again, Mwai, it will go into how we improve the benefit package and all that, but it has to be costed because we do not want to make a commitment that we are going to cover when the resources are not adequate. We must, for every commitment we make, we must work out the numbers and we must be able to pay for it. Otherwise, we can make this progressive. We can take it to the next level, assess it for a while, and then see what we can do. That good gentleman, Mr. Gikonyo, has also told us that we need a renal registry because he has said data is very important. Is that correct, Mr. Gikonyo? So, my good friend Anthony, it is possible for us and it is necessary. The reasoning given by Mr. Gikonyo there is to be able to effectively provide interventions, we must have a good body of data. Numbers are important. There are some people, Mr. Gikonyo, who are telling us that numbers are not important. That why are we registering people? Why are we talking about people who have been registered? Is SHA registry. You are telling us to do another registry. You know? Because you've said, what is your reasoning, Mr. Gikonyo, for the registry?
It's working. Reasoning, Your Excellency, is that we need to make data-driven interventions with evidence from the situations that we are going through.
I hope those who have arguments against our data are listening to Mr. Gikonyo. Mr. Gikonyo, you have said some, what your personal experience on what SHA has changed for the people who have conditions like yours.
Yes, sir.
And in your opinion, we've made very good progress.
Absolutely.
What do you tell those who are telling us we should scrap SHA?
They should pray very hard that they don't fall sick one day and they find themselves in a situation where they can not foot their bills, and if not them, one of their relatives. Let me give an example. If someone needs dialysis suddenly, and that is 80% of all the people who need dialysis, they find out that they need dialysis one day when they collapse, and they wake up in an ICU, and they are the last to know that their kidneys failed. Why? Because kidney disease is a silent disease. It will work on your body without you knowing. You will feel some changes which you will correct with Panadol and other adjustments, but eventually your kidneys shut up. By the time you wake up in ICU, you will have received probably 4 or 5 dialysis. So you will already be in the red for 50,000 shillings, even before you have been told what is wrong with you. That is how critical it is to have a cover that can take care of you when you're in that situation.
Thank you very much, Mr. Gikonyo. Mr. Gikonyo has told us one more thing. He has told us the best way to get out of, the whole space around dialysis, because dialysis is good because it saves lives, it prolongs somebody's life, but kidney transplant would actually solve that problem in a much more fundamental way. Is that correct, Mr. Gikonyo?
Yes, sir.
So, and he says there are now restrictions on how somebody gets access. It has to be a member of their family. And he has given us suggestions by way of feedback, which is the reason why we are having this conversation anyway. We want to know from citizens, how can we do this better? He has told us that we should expand the pool of access to kidneys to non-members of the family, and possibly create a framework where we can get organs or kidneys from deceased persons in a framework that is acceptable legally and morally. Is that what you're saying?
Yes, sir, but if we had a deceased organ program, we would expand donations to beyond kidneys, because we would now be able to get other organs that are transplantable, and a human body can give up to 8 organs that can be transplanted. So it would be a wider pool where even other conditions can be supported.
Is it something that can be considered? Is it something that, it tells us that there was already a conversation in that direction?
Your Excellency, we are, as a country, we didn't have enough policy and legal framework. But after what happened in Eldoret and the whole story of organ harvesting, the committee which Dr. Wala here, not the president now, but the leader of Kenya Renal Association, was a member among many other experts. That report now is before Parliament, both the Senate and the National Assembly. There was some work we were to do as a ministry, develop the policy, the framework, and the legal instruments, which we are about to finish. Parliament is ready and waiting for us so that we present to them. So that as a country, first we have the framework, the legal, and the policy, which I will bring to Parliament and the Cabinet.
So I think we can then tell John here that what you are suggesting is already under consideration. We must, however, guard ourselves against what we saw in the past, where citizens were duped into organ harvest scheme. Some of them, their organs were taken without them even knowing. And some of them were, conned and things. So we must have a robust policy and legal framework that is already in discussion. Then we can maybe progress and get to the suggestions you're making on how can we save more lives and how can we expand the pool of how a renal patient can access a kidney to save their lives or to share with another citizen. So I think that is a work in progress. The last issue that I picked from my good friend there is they need better participation in the policies that we are implementing. And I think he is just speaking to a constitutional principle. It is no longer a sterile provision of the Constitution, that public participation should be part of the engagement of us going forward. And therefore, I think what he's asking for is, as you develop the policies and the legal framework that affects people like him, they must be involved. And I want to commit Bwana Kikonyo, that is going to be the case, and you will you will participate.
Thank you, sir.
There is one more good lady. Sorry, I didn't get your name. Yeah, she has told us. Sharon. Sharon has told us about children living with disability and caregivers who are supporting children living with disability. And she has recommended two things. She has said we need to look at the package that is available to children living with disability, including the caregivers. What is it that we can tell Sharon and people like her who are helping with children living with disability? And she has recommended specifically that early intervention could actually make things a lot easier for both the children and also the mothers. And that these are children who deserve, support. What do we have to tell her? Mercy, do you?
Thank you, Your Excellency. If I'll start with the good news on your instruction yesterday at night, we started work on diapers, and the proposals are underway, and we should be concluding that by the end of October. And Prof. Jauko's team has already started looking at that. On what Sharon has raised, it is another area of progression that we need to work to. A child who has spinal bifida, which is a condition where the spinal cord grows outside of the body, requires care for life. And so it means that this child requires physiotherapy, speech therapy, nutrition therapy, almost every day, if not every other day. So what we need to do and what we are going to do is do the costings of that, determine how many Kenyans would be needing that service, what again the budget impact of that is, and how SHA can finance it. But Your Excellency, there's also one more area where the Council of Governors can support us. Kenya over the years has not invested in cognitive disabilities for children. We do not even have the right specialists in place. We have very few speech therapists, very few autism doctors, very few doctors who deal with those conditions. So there's some work that the ministry together with COG needs to do in training, in building this workforce, and then also in building the facilities that come with this. But from a SHA perspective, we're going to review the package and see what we start with. Do we start with 2 sessions of speech therapy a month? While we know that you require more, it's a progressive journey.
Okay. Sharon, I think we do not have good answers for you. Let me say that. But it is good homework. This is a space that is new. It is a space that maybe was forgotten. But I agree that it is a space that we must begin to, think about, whether it is mental health. It's becoming a very serious challenge. All the other issues that have to do with disability. That is a space that maybe the ministry and us, we may need to explore more and look at what interventions we can come up with so that people like Sharon and others who support people in that space can be attended to. Sharon, you want to say something?
Thank you so much, Mr. President. Okay, I have another one again. We have anticonvulsants. Myself, I take anticonvulsants. I'm epileptic. So these drugs are very expensive. And some of them, we get them at the hospital. Yes, they're being given for free. Unfortunately, some of them are very expensive. We don't get them at the hospital. So can SHA again put us on that kitting? And my question is my request is also for our governor, Mr. Sakaja. For many counties are doing assessment for children with disability for free. Why is it hard for Nairobi that our kids can't have their assessments can't be done for free. And if it's that difficult, can we also put it on SHA so that we may enable many parents to register their children when it comes to registration for persons with disability? I know he's asking himself which it's the National Council, the card for the National Council for Persons with Disability.
Okay.
So that it might help us to identify how many parents do we have, how many children do we need to have the diapers, how many children do we need for anticonvulsants, and how many children with disability do we have, how many persons with disabilities do we have. Yeah, thank you so much.
Thank you, Sharon. And I sympathize with Sakaja because he's almost in the same space as myself as to what exactly do we need to do here. Oh, you have something? Okay, Johnson.
Thank you, Excellency. I think it's good to be here, and I know many people are from the city. The first issue on occupational therapy, we provide that in our level 4s and in our level 5s. Occupational therapy, physiotherapy. At Mama Margaret, I know we have we're registering. We're doing the registrations, even of PWD. The benefit from free diapers and medicines like phenobarbital. Phenobarbital is available there. We have occupational and basic therapy as well as at MLKH, as well as a serious orthopedic unit over there.
I think she was saying, Johnson, the assessment. He said,
I'm getting to that.
Okay.
Yeah, I'm getting to that. Your Excellency, for occupational therapy, I know for sure it is free for assessment, disability assessment, I know for sure it is free at Mama Lucy Kibaki Hospital. But if it is not free in the other, my CEC is quickly checking. It will be free from tomorrow if it is not. I will direct that it is done. In case it is, that is very easy. And I know they are listening. But I'm just confirming, I know for sure it is free at Mama Lucy. We'll make sure it is free. I don't think you need to be charged for just that assessment, Your Excellency. Thank you.
Thank you very much. Now, there is one thing that is coming out of this, that we may need to expand our, health professionals, scope, to cover new areas. We seem to have gaps in certain professionals. I think somebody mentioned here that there are gaps in some expertise that may be necessary for us to handle situations that confront our healthcare facilities. We need to have the people with that expertise. I don't know whether in this room we have the director of Kenya Medical Training Center. Is he here? Yes. Yes, Daktari, last year we had a conversation. And we had a conversation on, expanding the footprint of your organization. You also brought to my attention that you needed to hire more lecturers so that you can expand the courses that you are offering in our Kenya Medical Training Center. In the context of the conversation we are having, listening to Sharon and the professionals we need in that space, listening to others here, and the feedback we are getting from people. In this year's budget, we have provided money for you to hire an extra 1,200 lecturers and people who will help in your teaching facilities. In this year's budget also, when you did request me, we've also made money available for students at KMTC for Higher Education Loans Board. I think 390 million or so. But I also understand that that money may not be sufficient. And I want to tell the good people, health professionals who are training at our Kenya Medical Training Center, that now, as we improve on the package for tertiary education, we have taken the law to Parliament on tertiary education placement and funding bill that will now cover all students at KMTC to access funding for their training, so that these gaps that exist at the moment, we will settle them. What do you have to say, Daktari, on listening to this conversation? How do we, or how will your organization, with a pool of health professionals that you are training, how will your organization help us and help, citizens who have different conditions, who require different professionals? How do you think we should approach this? And what kind of support do you need from me to be able to provide for beyond what me and you and PS Muthoni here discussed?
Thank you, Your Excellency. My name is Dr. Kelly Olwach, CEO, Kenya Medical Training College. Your Excellency, to start with, KMTC has increased the number of courses from 98 to 126. That is 28.6% increase in the number of courses. Your Excellency, thank you. We are talking about speech therapy. Your Excellency, Kenya Medical Training College now has a diploma program in speech therapy. We also have a higher diploma course in speech and language therapy, and also a higher diploma in audiology. Your Excellency, I'm cognizant of the challenges that children with disability face, one of which is delayed speech. And Your Excellency, the country did not have specialists in this area in the health field. Kenya Medical Training College, in response to those challenges, has now a diploma and a higher diploma for that program. And the demand, Your Excellency, for speech therapy services is exceedingly very high. I want to thank you, Your Excellency, for leading us into that direction. Your Excellency, I want to also thank you and discuss with the nation about HELP financing at Kenya Medical Training College. Your Excellency, in 2022, Kenya Medical Training College had 54,000 students. Currently, Your Excellency, the institution has 89,000 students, 700. Your Excellency, that is 36.7% increment in the number of student population in Kenya Medical Training College. The rise in the number of students in Kenya Medical Training College is in response to the challenges that the country is facing in terms of shortage of health workers. Your Excellency, one of the challenges that we also faced because of COVID-19 was global rise in demand for health workers. Your Excellency, because of the leadership that you've given us, we have had 185% increase in the processing of documents for those who are going out of the country. And we want to increase that to support our youth to get employment out of the country. Your Excellency, on the issues of training and the issues of help at Kenya Medical Training College, it has been an on and off challenge. Your Excellency, the first promise we had for consistent help funding of Kenya Medical Training College was in the financial year 2022-2023. Kenya Medical Training College, despite having a growing number of students, did not have a proper way of funding for those students because we exist in the Ministry of Health and not in the Ministry of Education. Your Excellency, in 2012-2023, Kenya Medical Training College received help funding equaling to 641 million. In 2023-2024, Kenya Medical Training College got 605 million. In 2024-2025, we got 511 million for student financing. However, there was a shortage last year where our students did not get any funding. Your Excellency, when I brought this to your attention, you were very quick to take action. The first action you took was to request Treasury to assign resources for Kenya Medical Training College. As a result of that, we have 392 million as a stopgap measure to support our students through training. We realize that the number of applicants for help is so high compared to this amount of money. Annually, we will require 700 million for new students and 500 million for continuing students. And so, Your Excellency, you gave a directive through a presidential directive dated 6th May 2026, requiring students of Kenya Medical Training College to get special funding through HELP to support the high number of students who are not getting. Your Excellency, this year's budget has 392 million, and we are also following with the support of my Principal Secretary to get students of Kenya Medical Training College be permanently put under help to end the perennial challenges that our students face. Your Excellency, I submit. Thank you so much.
Thank you very much. The good news, Daktari, is that we are changing help and combining it with COOPs into the tertiary education, placement, and funding in the bill, so that we combine the placement and the funding, so that for every student we place in a college or a university, we will have figured out the funding for that student. Because the development of our human capital is central to our development as a country. It is the single most important asset that we have. And I just want to give you assurance, and to the students in the Kenya Medical Training College, that this on and off trial and error is going to be a thing of the past. The same way we are funding all our students in TVETs and in universities, KMTC students will now permanently be part of that arrangement. Mercy?
Yes, Mr. President, I know time is far gone. I want to seek your indulgence. As you can see, many notes have been coming my way. My phone is ringing and many messages from the people in the room who still want to speak. We have a team from Moyale. We have persons living with HIV, persons with disability, on local manufacturing, local manufacturers. So if you allow, we can quickly hear from them, and then we wrap it up after that. All right. Let's go to Moyale first.
Thank you, Mr. President. Indulge me because I'm having cold. Yeah, so my name is Getu Samuel Sake. I come from Moyale, Marsabit County. I'm here with a team on this end. And also I'm here together with two elders to tell a story. Mr. President, we are really thankful to you and to your government for organizing this summit. Beyond 2030, we as a team from Moyale, we have a story to tell. There's so many beautiful stories being told here. But we, as a team from Moyale as well, we have come to tell a story that is unique to many of you. So if you will indulge me with your permission, I have two elders here. Though language is an issue, I will request maybe a translation that will tell a story, and later on I'll make a submission on the same. With your permission, we have two elders here. On the far end, Mr. Gabayo Osha, and also Pastor Mary. With your permission, let me pass the mic so that they can tell us the story, after which I'll make the submission. Thank you.
I'm sure they can speak Kiswahili. Wanaweza kuongea Kiswahili, hakuna problem. Unaweza ongea Kiswahili?
Borana.
Ama iko problem?
Yeah. nitamsaidia. Thank you.
Makanki Gabayo Washadani.
Kwa majina naitwa Gabayo Washa.
Moyale Lufe.
Mimi ni mkaaji wa Moyale.
Uji okan kanisa kesa tuji wa Jadda.
Nami ni mzee wa kanisa ambaye tunamtumikia Mungu pale.
Kabajama unenugaran dofnefi.
Mheshimiwa Rais, kile imetuleta hapa
shani Moyale namiedu sha infayadama.
Watu wengi wanatumia SHA.
Amo challenge amna.
Lakini tuko na changamoto.
Community ni ujasha tumitu mgonjwa didiko kubdidikagana ni sabaibiti.
Jamii wako pale wanapotumia SHA wanasaidika kwa magonjwa madogo madogo.
Amo maro economic areas nami oriti fata.
Kwa uchumi na watu wa huko ni wachungaji wengi wao.
Yo gariboni dufe wanarkaka wanamdurafuda.
Saa zingine kiangazi inapokuja inawapokonya kenye wako nacho.
Lukugurda okani yo fayada bani.
Wanapogonjeka magonjwa makubwa kama kansa na kadhalika.
Achiti yo stroke fargatan, yo accident fargatan, yo lafifa chabti.
Wapo wanapopata na stroke na wanapopata ajali na kufunjika mfupa.
Rifaro gar Meru fa korani.
Wanaandikiwa rifaro kupidane Meru na sehemu zingine za nchi.
Meru gar kilomita dipishani oli.
Na Meru iko mbali na sisi zaidi ya kilomita 500.
Adumdemu na mikaradwa.
Tukiwa tunamsafirisha saa zingine watu wanaaga.
Time na chidakabani finamikuni dibu argate karalu buda.
Kwa sasa kwa vile fikisha pale haraka mtu anafariki.
Namigarile serikal dibi ifade mujariba.
Kwa ajili ya ubali watu wengine wanavuka pande ya Ethiopia wanaenda huko kusaidika.
Akidan samarro full area suno kamfula suni hospitali akidan sa dibu gurda kan karkarun dandenefi.
Kwa vile hatuna hospitali ambayo ina deal na mgonjwa huyo.
Achi gar Meru dufuitin transport mbeso guddo.
Kutoka Moyale paka Meru kukuja ni transport ni mingi.
No kanisa yo kan committee lewalini.
Pamoja na jamii na watu wa kanisa.
Wani afura callani takamin gumi fayada kan dakamna ya jedan yani.
Sikufanya tu jambo la kiroho lakini tukakaa chini tukafikiria tutaweza saidia jamii wetu namna gani.
Akamini diyotoni gunu dihati anna nami karkarsar gata.
Ndio tukafikiria kwa jinsi gani ndio sasa tuwe na hiyo facility ambapo watu wanapata msaada.
Committee wale walagene Moyale community hospital wanjaran obja kasi objanne.
Tukawa na nia na ndoto ya kujenga ya hospitali ya jamii kule Moyale.
Akanami karkarsar gate ujintun tashayale akitansaxin demtu.
Ili watu wapate msaada na mambo ya SHA pia ifanye pale vizuri.
Tamisho nani tidaru
ya misho
debi kun ganadera de mujira area sunit.
Kwa hiyo sehemu sasa hiyo shida inaendelea kwa muda mrefu.
Nairobi odufan distanti mfago.
Wanapokuja Nairobi ni mbali.
Meru mfago.
Na Meru iko mbali.
Yo wikum dabarte wikilam kadabarte jarsi toka kumale fayada be.
Si mbali tu wiki 2 iliyopita kuna mzee alipata shida.
Masa toko lam kesati haraka dakaba jedan hospital.
Walipompeleka hospitali na wakasema mfikishe tu haraka iwezekanavyo within 2 ama 1 hour.
Agmeru dandani wana watu wadakabon dandano.
Huyo mtu sasa hatuwezi mtu kumfikisha huyo mtu yani kwa masaa 2 ama masaa 1 afike Meru.
Amma warisune nametuna do wakaratu yarsisun dikom ka waqiti dakabe hospital ambai.
Sasa tukiwa tunaomba sasa Mungu akamsaidia huyo mzee akafika hospitali Meru.
Namitok accident targate yo matafa di bargate ochasun karkar sargachun rako.
Kama mtu mmoja anapopata ajali apate shida kichwa kupata msaada ni shida.
Tanafi kabajama.
Kwa hivyo Mheshimiwa Rais
Nullen objutan kamna.
Nasi tuko na hiyo maono ya kujenga hospitali ya jamii kule eneo la Moyale.
Akati barcuma guddo fudhatte nullen xixiqqaa fudhannu assanti.
Nami pia tunakualika ili uweze kuungana nasi tuendeleze shughuli hiyo.
Asante sana.
Haya, ngoja bwana Gabeio.
Yes.
Akam?
Dasa.
Unaelewa Kiborana?
Dasa.
Yoya. Mimi nakuuliza kwa sababu sasa umesema mnataka kujenga I understand ile unaniuliza ni kwamba tuwe na hospitali Moyale ambayo inaweza kushughulika na haya magonjwa umesema yanayozidi dispensary ama health center. Na mimi nataka ujue hivi, unajua Sololo, pale Sololo sasa tuko na hospitali level 4 na nilitumana equipment kupitia kwa wanajeshi wetu, tulijenga hiyo pamoja na gavana wenu. Sasa kuna equipment pale Sololo. What I think my good friend is saying there is the challenge of us having facilities that have capacity in level 4 to attend to some of the situations that now they are going to a hospital in Meru. So I think we understand what you're saying, and thank you for the initiative that you have started to maybe build a facility for yourself. But I think meanwhile, we can find a mechanism working with the county government to equip some of the facilities under our national equipment program. We can equip some of your facilities so that they can serve the people of your county. Please explain to him. Thank you very much. I think you can explain to him what I have said in the language that he understands.
Allow me, Mr. President, to pick two more.
Mr. President,
Sorry.
let me just make a submission in a minute.
Yes.
Yeah, thank you so much for your indulgence again. As you have clearly articulated, the challenge here is the distance. And beside distance, this is not interdiction to Moyale General Hospital and Marsabit Referral Hospital. But if you look around even the entire Kenya, those hospitals that are serving Kenyans properly and people are getting service from there are mostly mission hospitals. And within our region, one that we have is Sololo Mission Hospital. That hospital has saved many lives. And the other closest, which is nearly 500 kilometers away, is Kirua Mission Hospital in Meru. And now looking around the issues that we are seeing, why are we here as a church? It's because if most of the time we go out on a medical camp, and the most experience, the challenge that we see and witness every now and then is that there is that recurrent issue, especially around Kargi region in Chalbi area, Kargi to Sololo to Moyale. There are cases over decades, cases of cancers, especially throat cancer and stomach cancer. One good case example is my Shosho. My Shosho passed away back in around 15 years ago. She passed on with cancer, and many other cancer cases are there. Just imagine the distance between Moyale to Nairobi, or the distance from Moyale to Meru. That is a life. So the challenge here is the challenge of diagnosis, after which this issue of treatment, and look at the distance. All this issue is really troubling our people. That's why we are saying, as a government, kindly we request that if these facilities, as you have clearly put, if it can be brought closer to us, probably Marsabit or Moyale, it will be helpful. So in that endeavor, we as together with other stakeholders, especially faith-based organizations. We have been keeping in touch, we have been talking, and also the communities around and other stakeholders. We tried to reason, and we said we will put up a hospital that we seek mobilization from different areas. As a result of this church, they were able to provide 8-acre piece of land for such a mission hospital to be built. And so as a result, they have consulted different organizations, and already plan is underway, and they have already started construction. Therefore, here, as a team here today, as we address the plight and issues facing the northern region, because most of the time, let me say this, Marsabit and Isiolo, most of the time they are being confused with northeastern region, that is Garissa, Mandera, and Wajir. Most often, we get lost under there. But we, those are the northeastern, but the actual northern, those who are there, we face these challenges. The challenge, the Moyale General Hospital, it's up the border.
Excuse me, if you allow me just to interject, Mr. President, I'm being told there is a level 5 hospital in Marsabit that is currently undergoing construction by, this is from Dr. Wilson Arwasa. I don't know if he's in the room. Maybe that can...
I think Duale is here.
Duale.
But
Okay.
I think the point he's making is that we should make more facilities have equipment that can help in the treatment of cancer and all the other. And I think this is a matter that had already been spoken to by the chair of the council earlier, that we need to assist counties to be able to have the requisite facilities, especially on matters to do with cancer, because it's a real disaster in many communities. And in the past, people had to travel, to Nairobi and to all the other places. With now the elevation of some of the facilities to level 5, we should be able to make those facilities available, in those hospitals, so that we can deal with the case of Moyale.
As I see it, kindly allow me to present this document. One, here we have a concept paper on our project, as well as an invitation for you to attend in our fundraiser. Thank you so much for your time.
Thank you.
And God bless you.
Thank you.
All right. Thank you. Thank you. Thank you for that. Thank you, Mr. President. Allow me to bring in 2 more based on our conversations yesterday night. We discussed a lot about the equipment, services, and local manufacturing, availability of medicines. And I'm told we have a local manufacturer of, I think, medicines that would want to speak. And then we had a conversation about registering Kenyans to SHA. I think the number is, once a country is at 85%, then you are well on the way to UHC. And Mombasa County, Governor Abdul Samad, as that yesterday, was at 84%. And the co-chair of the UHC 2030 would want to comment on that. So allow me to pick on those 2, on the local manufacturing. Behind me. Okay. Who? All right. Your name just in under 1 minute, please.
Thank you very much. Your Excellency, the President, all the dignitaries, my name is Dr. David Maina. I'm a pharmacist in the field of local manufacturing, and I'm here on behalf of my fellow colleagues who are manufacturers. We want, first of all, on behalf of the local manufacturers, to greatly thank you for this audience and for your commitment towards universal health coverage. We are very grateful. We've actually been looking for such an audience for a long time, and this is the right time. Your Excellency, we have about 40 manufacturers, local manufacturers in Kenya. The 40 manufacturers produce medicines and take care of about 30% of the local consumption. Your Excellency, that's very key, because what that means is that the other 70% is not made locally. That means it is imported. Let me also emphasize that the percentage is not in terms of the number of packets of medicine, it's a value. So if the local manufacturers are doing 30%, the 70% imported is high value. And if we did it locally, it could cost us maybe 30% or 40%. Having said that, We also, as a manufacturers, we employ about 1,500 people, about 15,000 people directly, and many more in the value chain. So local manufacturing is a very, very important docket. When I heard many people talking, Your Excellency, they were all referring to medicines, dawa. In fact, some said, unatibiwa, unaambiwa hakuna dawa. At the end of every service delivery, health service delivery, is a product. That is the dawa. And that's where we are placed to ensure that we provide those medicines to the patients so that the whole ecosystem of treatment can be complete. When COVID struck 6 years ago, there was a general crisis in supply chain of pharmaceutical products. In fact, Kenya could not even import a simple sanitizer. Even masks were being imported, that used to be imported, we had a shortage. So I'm saying that because our space, and why this is very important, has two aspects or very objectives. One is to play our role in universal health coverage in terms of supply medicines, quality, affordable medicines. The other very important one is actually disaster preparedness. If another COVID came, that would be a disaster. Would Kenya be prepared? How prepared are we if we are importing 70% of our medicines? It's a big security threat to this country and all the countries in the region. With that, let me acknowledge your support, Your Excellency. 2024, about 2 years ago, we were here at KSAC, and you gave a commitment that Kenya need to cut from 30% to at least 50% supply of local produced products by, I think, 2026, end of this year. With that, I'm happy that we have gotten very good support. Let me give credit. We have a very good Ministry of Health that is very supportive, extremely supportive. There's even a department of HPT, Health Products and Technologies, at MOH that is supportive. In fact, recently, they mined all the data and have a local manufacturing, pharmaceutical manufacturing strategy that was recently. That is very welcome. We also acknowledge, Your Excellency, that you are actually the champion of pharmaceutical manufacturing in the region, the IGAD region. And we are proud that our president is actually the champion. We have good support. However, we have some challenges that we are facing that are preventing that achievement.
Sorry to cut you. If you could just make that brief and maybe do it in a minute.
Yes. I'm going to be very brief. We have some 4 challenges I'll highlight that are making that achievement scaling to 50% become a bit difficult. Why this is important? Because despite the support from MOH, we feel that the challenges cross across the ministries. And it's only probably from your level that can be sorted out. I'll be very brief with that. Number one is the cost and the competitiveness of our local products. We have a situation whereby our inputs are very expensive. Because of compliance with quality, and especially now Kenya is undergoing maturity level 3, ML3, our factories are very expensive to run. High electricity bill, all the inputs very expensive. In addition, we have taxation that is not pro-local manufacturing. Especially, we have excess duty on packaging material. Recently, there is VAT added on some raw material. I know that's being sorted out. Why that is, let me add that despite that, we have import duty that is exempted. That's very good. We don't pay import duty. We don't pay IDF fees. We don't pay levy. That's very welcome. But the few things that we pay, like excess duty on packaging material, it's making our products very expensive. We have been engaging MOH for the last 3 years. And we feel that there's a disconnect between MOH and Treasury. Because Treasury on one side says that they need to protect local printers, local paper manufacturers. So they put excess duty on imported packaging material at the expense of pharmaceutical manufacturers. But we can solve that by actually ring-fencing the local manufacturers only. That is an example that imported glass bottles have excise duty into bracket apart from local pharmaceutical manufacturers. That can be done for packaging material. But that has not been done for the last 3 years, and we kindly request if that can just simply be done, we'll be more competitive. The costing part of it also, we are competing with imports, the 70%, majorly from Asian countries. Those imports from their source have been exempted all the duties, and in addition, they get export subsidies when they are bringing to Kenya. You find such that you're competing with a product that is all exempted, well covered by the government, and you're competing with it here. That is there as the competitiveness that we are asking for. Number two challenge, because I want to be brief, is about regulatory challenges. Among the 40 manufacturers that I mentioned earlier, inspection by Farmers and Processors Board last year. And it's a good inspection because it is towards maturity level 3, which we fully support. We are in full support of level 3. We think it's a good thing. But despite that, that inspections made 12 companies be suspended their licenses. That means from the 40, you hive over about 1/3. What that means in short is that if you are doing 30% supply to Kenya, you are removing 1/3 of it. You are left with 20%. So we are likely to be in a worse position now, although it's temporarily because of the inspection, than we are then. The other part of the regulatory challenges is that those countries we are competing with, where they are registering a product, they take 3 months to 6 months. In Kenya, we take about 12 months at best to 36 months. That means if we want to have more products, 50% achievement, we have to register more products. There needs to be a fast-tracking method to have those products in the market. Your Excellency, you mentioned, and rightly so, that you negotiated reduction of price by one foreign company from a certain figure to 1/3. The question is, they were making profit when they were at 100%, they are still making it at 30%. That's the kind of level we are losing by importing. If those resources in foreign exchange can be put in local manufacturing towards the taxation and other cost remedies and support for registration, we will actually achieve that faster. Number 3, and I'll be very brief, is about capital. Okay? We have a system whereby it is very capital intensive to run pharmaceutical companies. Just the way we have other funds for agriculture and other departments. If we could have a pharmaceutical industrial fund, and we don't want goodies, we don't want anything for free, just easily borrowing and payment, it will help a lot. Because banks perceive pharmaceutical manufacturing to be a specialized field and therefore very risky. They are not willing to ready to maybe buy a machine that is not universally used by other people. Finally, we have KEMSA, which is the biggest purchaser of our goods. KEMSA and county governments. KEMSA and county governments have a policy of the lowest price. That means the initial challenge I mentioned about the competitiveness applies when you're tendering for KEMSA. You find that the imports, we can't compete with them. Therefore, despite maybe a 50% allowance, is not enough to attract many local manufacturers to sell more. And even after selling, and this is where maybe the KEMSA needs to hear, takes about 6 months to 1 year to pay. If that can be sorted out, we'll scale up to more produce manufactured We are ready to support you, Mr. President. If we can have that support, we can actually make quality, affordable medicines, not just for our country, but even to export to our region. Thank you very much.
Very well put, Mr. Minor. Yeah, very well put. I have a couple of questions for some. I think we need to answer this question. I mean, we have transitioned. We were saying initially financing is critical. And then we said human resource is critical. Now we have gone to, without medicine, there is no healthcare, according to Minor. So everything in the chain looks like it is critical. Agreed that we're producing only 30%. That was in 2024, we had a conversation. And my instructions to KEMSA then was we give priority to locally manufactured products. I want to understand first whether, and I had even specific examples. I had, for example, one facility in Kilifi, Revital, and I think they are here. And Revital was manufacturing a lot of stuff in Kenya and could not sell to Kenya, but they were selling to other countries. And it was because of a conundrum at the KEMSA. And I said that should be undone. I don't know whether the CEO of KEMSA is here. Yes. Can you explain to us, I know there was another CEO, what is the, how has things changed in terms of your purchases? We insisted that local manufacturers should be given priority. Specifically, are you now buying from Revital and they are here? If you say something that is not correct, they will say something different. Just tell us.
Thank you, Your Excellency. Yes, so local empowerment is very important, including manufacture of pharmaceutical products. We are keeping a tab on that. Revital can attest that nowadays they don't complain, they don't write letters. We do a lot of procurement from them. But in general, under your direction, we got instructions in order that we should do more than 40%. I can attest here that our procurement from local manufacturers is 52%. And in fact, from international manufacturers through our local suppliers, when you add those two, over 70% we buy locally. So the preference in procurement works when there is an international competition. We give, according to the Public Procurement and Asset Disposal Act, we give 15% preference to the local manufacturing. And by local manufacturing, 100% fully owned by Kenyans, or more than 50% owned by Kenyans, they enjoy a 15% discount. The only trouble comes in, I think Dr. there has talked a lot about other issues outside us, which affect their costing. So as a government, maybe that can be looked at, but yes, we do. And
Thank you very much. Thank you very much, Wako. Revital. Yes, please pick the mic.
Mr. President, thank you. I represent Revital here. I would like to attest to what Dr. said. Yes, we have been getting local tenders and we are able to get that preference. However, mobilization of funds after the supplies is something what we are still chasing on. So
okay.
one tick box checked, but the second one is still in the progress. And just to add to what my colleague said, just like our neighbors, they come up with policies like BUBU, like Buy Uganda, Build Uganda, wherein they are giving preferences to the local manufacturers by increasing some taxes for the imported medicines and products. We are also looking for support from you on that.
We will go there. Yes. I will go there shortly. Sure. So I just wanted to confirm that we have moved our locally manufactured products in KEMSA from what it was to now you tell me 52% of your purchases are from local manufacturers.
Yes, Your Excellency. I only have one problem with the manufacturers, which I'll take the opportunity. When we strictly label the advertisement to attract only local manufacturers, then they tend to hike the price because they know the international bidders are not in. So I plead with them, when they see it's restricted for local manufacturers, we are a commercial entity. So if they don't give us room for markup, we'll not be able to pay salaries.
Minor, there is some homework for you and your team there. You know, we do not want you to shortchange us. You know, the moment we lock out your competitors who are international, you must not do a cartel business here and hike prices, you know, really. Because we really must be honest with ourselves, because this is public money that we are using, and we want to get value for money. So I think the issue raised by the CEO of KEMSA is an issue that you must address so that we can support local industry and still get value for money for the Kenyan people. We do not want to say, because it's a local manufacturer, then we pay more than, you know, is reasonable for us. That is one issue. But my instructions to KEMSA was that progressively, we must get value for money, but we must support local manufacturers. You have raised a couple of issues. The first issue is we will do affirmative action. I want to confirm to you, we will do affirmative action on buying from local manufacturers. That is number one. And I want to encourage counties, when they too are buying, let us try and see how we can support local manufacturers. You have raised some issues on taxation. We did what Maina said. We removed some taxes, IDF, all the other taxes. You are telling us to go further and, you know, ring fence, because, you know, we do not want a situation where we are promoting local manufacture in one space and we are undermining another space. When we put duty on imported paper, it was because we also wanted to support local paper manufacturers. So we must also balance between manufacturers of local paper and the pharmaceutical industry who may want to use paper that is not locally manufactured. And what we should be able to do, and I think Duale, your colleague in industry, Lee Kinyanjui, and Badia Treasury, you should be able to sit down and encourage local paper manufacturers to manufacture the paper that these good people can use in the pharmaceutical space, so that we have, we sort out both sides. And now we will be willing to have a conversation, Maina and your team, on how we can bridge the gap between local paper manufacturers and yourselves, and whether it is absolutely necessary to ring fence paper for packaging for pharmaceutical companies in the manner in which you have suggested. Number three is we are trying to transition the country to ML3. And, you know, we have to meet certain conditions. If some of our local manufacturers don't meet those conditions, you know, we will undermine the position of the country if we don't meet certain international conditions. So unfortunately, we will have to, you know, to ask some of your local manufacturing entities to up their game, honestly. And the Duale and the PPB people, and Duale, do you want to say something?
Excellency, I know Maina very well. And I had a session with the Kenya Pharmaceutical Association more than 5 times. Today, under your leadership, we have done the reforms that has never happened in our country under BPP. And I want to share this with you. Number one, One you have answered. Minor is telling us to protect local manufacturing. But the same minor wants to go and import packaging from outside, and then we remove duty. All that we're telling minor is there are competent companies in our country who do the printing of packaging and who gets that favor from the National Treasury. To Your Excellency, as we transit to ML3, which you have directed, I mean, Kenya is big, it has a big pharmaceutical base for the country and for the region. Kenya is about to attain ML3 by October this year. For us to do that, we have stopped all parallel importation. Because parallel importation was where a lot of fake and counterfeit medicine used to enter our country. In fact, 2,500 products have been removed from the system of pharmacy and poison board to make sure that we, number one, for the safety of our citizens and the dignity of our patients, we must stop counterfeit and fake drugs. So 2,500, there are many people who are complaining. Number three, Your Excellency, and I think minor must be be aware, is that for you to establish a pharmaceutical manufacturing firm in our country, all the equipment and machineries are of free duty. They have a huge, no any other country in our region gets that kind of tax incentives. All they need to do is to get a letter from the Ministry of Health to the Minister for Finance, and the Minister for Finance will write to KRA and they get all the incentives. And that is what we did in the last 4 years. Today there are more than 12 new manufacturing pharmaceutical companies now. Two, when you created the incentives that the local manufacturing preference be done by KEMSA, a lot of now Kenyan investors, working maybe with other foreign investors, are now establishing their farms in Kenya. So the reform that we are undertaking, I know the one that he wants me to talk to the Minister for Trade, Minister for Finance. We are in engagement. But again, we must balance. The kind of incentives our pharmaceutical industry is gaining, Your Excellency, is so phenomenal that the element of the packaging, which is very important, all that the National Treasury is saying is that we have given that incentives, that tax incentive to locals, not that you bring it from outside. And I can confirm that Revital, under your direction, and all other companies, what the CEO is saying is true. What they used to do before is they used to mix things, and you're aware of that. Now they're doing specific procurement for specific items. So Revital, unlike before, now they sell to. On the issue of the payment, I think that is now a commercial interest, 90 days, 45 days, 60 days. Social authority under their contract is 90 days. So I think that's something we can discuss. But Your Excellency, the reforms that you asked under PPP is on course and is for the benefit of the country.
Thank you very much. I think this is a fair conversation. Minor, you agree. It's a fair conversation. I think you have asks. They must be, balanced with other. But I think if there is one space that I am very confident about, especially after the meeting I had with the manufacturing community in Kenya, pharmaceutical manufacturing fraternity in Kenya, we have provided sufficient incentives